So why are we here? Well, first of all, it's just great to be here with colleagues. I think that's a really good, healthy thing to be doing. You know, we've got specialists from the Cancer Centre and specialists from community here in the same room together talking about how we look after patients, and I think that has to be a good thing. There is, though, a fantastic opportunity in South East Wales. We can do things differently for our patients in the future. Elise alluded to the Transforming Cancer Services plan. I have to declare a conflict of interest that I'm part of that team as well. But when we look ahead to healthcare in the future in terms of the increasing demand, the increasing complexity, the increasing survival even, and some of the numbers that are projected, you think we have to do something different. It is going to be difficult, it's going to be a challenge, but I think if we work at it together, we can rise to that challenge, we can maintain the care that we give, and we can actually improve it, and we can do things differently that improves the care for the patients, and it is all about the patients. So cancer treatment has changed a lot and continues to change a lot. It's hard for us to keep up. There's so many new things coming through, new technologies, new treatments. So goodness knows how other people can keep up. I see patients in clinic and they're on diabetic drugs I've never heard of and cardiac medications I've never heard of. And we do use a lot of jargon as oncologists, I know that. So it's a question of how can we best help you? We've touched on a few thoughts already, email contact and things like that, and you know, I know Jazz has been writing these things down, and we'll take those back and see how we can try and implement those. So I've tried to bring out a few themes that might be relevant for your practice. I've worked with Elise to try and shape this, not around what we would do as an oncologist, but you know, describing what we do and trying to make it understandable and worthwhile. It's going to be focusing on two patients. What I've tried to do is pick out some of those words we've sent out already during the talk, and then we can discuss those and describe them and things like that. So that might give you some of those answers. And one of them's on targeted therapy and one of them's on immunotherapy. And I'll leave that hanging there just for now, not to give all the answers away just now. Lung cancer is sadly still the biggest cause of cancer death. About 20% of people die from of cancer deaths, about 20% are due to lung cancer. The next biggest is bowel cancer, which is at 10%. So this is a huge problem. There have been inroads into treatment and improvements, but 5-year survival, long-term survival is sadly not improving. And when you look at outcomes, Wales does not compare favourably with other similar countries. Bit of jargon, about 80% of lung cancer is what we call non-small cell lung cancer. I don't think that's a really good term these days, because all that's telling us is that it's not small cell. It doesn't really tell us what it is, it tells us what it isn't. So we've tried to move away from that into a positive description of what it is, and our pathologists love this because we're saying, well, you have to tell us what you're looking at, and they say, well, it's cancer. So we try to split it up into adenocarcinoma, squamous cell carcinoma. There's other rarer things, large cell carcinoma. There's something called NOS, which is still allowed, which is kind of lung cancer not otherwise specified when they really can't classify it. And this is important because there are treatments developing which we use for different patients with different types of lung cancer. So it is relevant to our clinical practice. About 15% is what we call small cell lung cancer, which is a slightly different entity. That's kind of like a neuroendocrine tumour, tends to spread around the body. You'll work out that 80 and 15 doesn't add up to 100%. There's a 5% smattering of other things. And outside of this, there are also a group of patients who have what we think is lung cancer, where we never get a tissue diagnosis. You know, the elderly, frail person with obviously advanced cancer where there are limited treatment options. You know, it wouldn't be right to subject everybody to a biopsy for an academic answer. But some of the changes in treatment these days are challenging that approach. And we're having to rethink who it is right to try and do a biopsy on, because there are some treatments that you might start using in these groups of patients where previously you wouldn't have a treatment. Just a bit of background information to our services. The yellow dot is roughly where Velindre is. That's where we're all based. But we spend a lot of our time away from Velindre. So this is South East Wales with our health boards that we work with. And the lung team go and do clinics away from Velindre, so we see most of our patients in the health boards locally to where they live. So I'm there up in Neville Hall Hospital in Aneurin Bevan. We've got two down in the Royal Gwent, Alison and Paul. James in Bridgend, he's in the back of the room there. Cardiff is served by Jason Lester and Emma Hudson. They do most of their clinics at Llandoch Hospital. Louise Hanna's in the Royal Glamorgan, and Jake Tangway goes up to the Prince Charles Hospital. And this is replicated across different tumour sites. So we have a geographical spread of our specialities and a tumour site. So if you've got breast cancer in Neville Hall Hospital, there'll be a different oncologist looking after you if you've got lung cancer in Neville Hall. And I don't know if you know this. Is this familiar to you, or is this...
Only because you get the letters and things.
Yeah. But I thought maybe just some background information in terms of how we're structured might be of use. Jane is a 45-year-old lady, young, fit, active, distant ex-smoker. She smoked a bit in her 20s. Presents with back pain. She thinks it's occupational. Takes a little while. She ends up having an MRI scan. She actually works in healthcare, so she knows a lot of people anyway. And unfortunately, her back pain is not occupational. So this is her MRI, and the T3 vertebral body, where the big red arrow is. That's not the cause of her pain. I'll put that on afterwards. It looks like a malignant deposit in her spine. Sad face. Not a good place to be. So this is a young, active lady who's had a major change in her life now. So the question is, what is that? Is it a primary bone cancer? Is it metastasis? We don't know from the MRI scan. So she gets referred through very quickly. I think this is potentially one of the areas of difficulty in terms of how we're set up. I look after people with lung cancer. If you've got lung cancer, you'll come and see me. We don't know what kind of cancer she's got. So where does she go? And actually, it was helpful that she knew the system, so she got into things very quickly. But I had an email 2 weeks ago from one of your colleagues, very similar story. Somebody with back pain, organised a scan, looks like cancer, who do I refer to? So I said, well, link in with me, I'll take things forward, and then if it turns out to be a different type of cancer, I'll then refer on, but we can take up that person's care. And we could actually have that dialogue. He said, patient's coming to see me in 3 days' time for the scan results. So we had a plan in place before that patient came. So she had some scans, and it looked like there's a mass in the lung here, and that's the same lesion in her spine. Oligometastatic disease I put in here as one of those words that we use. So metastatic disease people are fairly familiar with. It means cancer spread from one place to another. Oligo means medium or small, so it's not very much. So there's a concept coming through which is quite trendy in the oncology world of something called oligometastatic disease, where you see just one or two metastases. And we're starting to think about that differently. It may be a different biological entity to the typical cancer that spreads throughout the body with multiple liver metastases or lung metastases. It may be that we can treat these patients slightly differently. And there is the possibility of, if there is truly only a very small amount of cancer in the body, treating that with potentially curative intent. The conversations around this, the communication, the co-production of decisions is quite delicate. But we're beginning to think about maybe treating a group of patients differently. And that's something that you might hear in letters or discussions.
And just say something like colorectal cancer, you would treat that. It varies between cancer sites, doesn't it? This is just lung. But other cancer sites with oligometastatic disease, we would be thinking about curative intent, like breast and bowel cancer now. Sorry for interrupting, but I thought it's quite an important point that scenario is changing very rapidly in colorectal cancer, for example.
And it does vary as well, that this is a lady who's presented with a primary and a metastasis at the beginning. And that's different to someone who's had, say, a primary breast cancer diagnosed and then 3 years later there's a single lung metastasis. So whether it happens all at once at the beginning or later on is also very different. There's lots of different subgroups in this, and we're still trying to work out what it means. So how many areas? What scans have you done to diagnose the areas? Is it at the same time? Is it later? So it's an evolving area, but I thought it was something that's worth just mentioning. Just a side story, not related to this lady's care, but another one of those buzzwords, if you like, stereotactic radiotherapy. It's linked with this oligometastatic concept. So radiotherapy we often use if it's, say, the palliative setting, just one beam or a couple of beams for a short course of treatment for symptom control. For radical radiotherapy, where we're trying to cure a patient, we'd use a more complex approach and give a course of radiotherapy over about 4 weeks or something like that. I can talk about radiobiology and why we do that, but we might be here till the early hours of the morning, so ask me afterwards if you're interested in that. I am available for after-dinner speech and talks as well if you're really desperate. So stereotactic radiotherapy is where we use a very high dose, an ablative dose of radiotherapy for treating very small things. So this is someone with a primary lung cancer, and we've got lots of beams coming in. We can map the doses through our planning technique. You can map the doses to the tumour and also to important things like the spinal cord or the esophagus or the heart or the lung or the skin, so you can get an idea about safety and side effects. And we tend to use 1, 3 or 5 treatments, so a much smaller course, but a much bigger dose. And you can use this for primary tumours, or you can use it for a small number of metastases. James does stereotactic radiotherapy for the brain, similar principles, small number of metastases. And we're doing it for lung and other parts of the body as well. You do need to select your patients really carefully, critique the evidence base, and look at the value and the worth of the treatment. But it's an exciting opportunity and a good possibility to offer our patients. And one of the other good things of this, if you're giving someone something like a local treatment like radiotherapy, you may then not need to give them chemotherapy. So you may be using one treatment instead of another with a very different but potentially less risk of side effects. So we thought, oh, we're in the MDT, we're thinking, is this oligometastatic disease? Can we do something like this stereotactic radiotherapy? Do you know what this is? Sorry?
Isotope bone scan?
It's related to an isotope bone scan. It's a PET scan. Yeah, so this is what a PET scan looks like. So traditionally, we would stage a patient anatomically with a CT scan or an MRI scan. How big is the cancer? How big are the lymph glands? Are the metastases? A PET scan is a metabolic scan. It's linked with a CT scan, so you still get the anatomy. But they inject radioactive glucose, and cancers, being metabolic things, take up that radioactive glucose, so when you put somebody through a radiation detector, it lights up in the area. And there are new things coming through, new injections, so other options, so you can do radio-labelled PSA detectors and things like that. So if someone's got prostate cancer, you can start looking at prostate metastases. And you can see here, this is her primary tumour, has lit up very bright. There's actually areas in her spine. There's a metastasis in her shoulder there, and there are other lymph nodes that we can see in different parts of the body. So we've done this scan, and it's helped us look after this lady, because now we think, well, she hasn't got this oligometastatic disease. She's got quite widespread metastatic disease. And that area in the spine, although there's no neurology, we're worried about spinal cord compression because it's collapsed. It's getting close to her spinal cord. She's young and she's fit. And that's the critical area in terms of her prognosis. Because if she does lose her leg power, it's a huge impact on her quality of life, and then that lack of mobility leads to other problems, DVTs, infections and things like that. So making sure she doesn't get spinal cord compression is really important for this lady. So she's got a metastatic lung cancer. It's an adenocarcinoma when we've done the biopsy. This is how we describe staging. So we could use the TNM system, the tumour, lymph nodes and the metastases. That's what T, N and M stand for. And then we get down to a stage grouping of 1 to 4. Stage 4 means metastatic disease. Stage 1 usually means a small tumour that hasn't spread to any lymph nodes or anything like that. The biopsy has shown something called an activating EGFR mutation. Has anybody heard that phrase ever before? Okay, good. So this is a genetic test that we've done. We send the sample down to the genetics lab in Cardiff, and again, we're very lucky to have them supporting us. Most lung cancers are related to smoking, and as you smoke and inhale all those carcinogens, you get multiple genetic mutations, and it's a mess when you look at the genome. It's very mutated, and each of those mutations drive the cancer cells to mutate further, replicate, and grow. A small number of patients have a specific mutation in their genome which drives that cancer. It's called a driver mutation. And a bit like roads or the M4 in South Wales, if you close a road in a city, there's lots of other roads to come round. If you close the M4, there's absolute chaos though. So this is the one thing that is telling these cancer cells to grow and divide. And the happy thing is we've got some drugs to treat it. So if you give patients these drugs, they're oral therapies. This is what we call targeted therapy because it's targeting the specific mutation. It's a tablet. It's not the same as cytotoxic chemotherapy. You've got a much higher response rate and a better overall survival, so it's a better treatment. It is still palliative. I don't think we're at end-of-life treatment here. It's not palliative as in end-of-life care, but it's palliative because we know we're not going to cure this lady. But her prognosis could still be a number of years. Palliative does not mean end-of-life anymore. And some patients are on palliative treatment for 5 years or even 10 years with some cancers. She also had some radiotherapy to her spine because of the worries about that spinal cord compression and the pain she was getting. The targeted therapy we opted for was something called gefitinib. I've underlined the nib here because anything that ends in a nib is an inhibitor of tyrosine kinase, and they're usually tablets. She also went on to a treatment called denosumab. Now, MABs are monoclonal antibodies, and they're usually injections. And I know that we're not the only teams who use monoclonal antibodies these days. Lots of other people do as well. Denosumab, I think, is also used for osteoporosis. So it can help strengthen the bones and prevent that vertebral collapse. So the combination of these we thought was the best thing to get us started on. And she did very well, actually, within the confines of what we're expecting and hoping for. 18 months later, though, it doesn't project brilliantly with the liver. She's got widespread but small liver metastases. The area in the chest is controlled, and she's sadly developed multiple brain metastases. The liver is difficult to biopsy because they're small. We can't really biopsy the chest because there's not much to see there, and biopsying the brain is very difficult. So we have difficult conversations about what we're going to do, and we're now at the point where her cancer's progressing despite treatment, and it's difficult to know where we're going next, so it's got two sad faces. Luckily, we had a colleague called Dan, and he's working on something called circulating tumour DNA. Is that a phrase that everybody in the room is completely familiar with? Okay, so this is another trendy thing in oncology. So we've come to realise that as cancer cells, die either through necrosis or apoptosis, they release little fragments of their DNA into the bloodstream. And if you do a blood test in the right way and save it and get it to the genetics lab very quickly, you can isolate that genetic material just like you can do from a biopsy. It doesn't work with every patient, but it's worth thinking of for some patients. And it's called it's either called circulating tumour DNA or cell-free DNA or a liquid biopsy, because we're looking to do those genetic tests on a liquid sample. So we did this as part of Dan's project, and we found, again, getting a little bit technical here, another mutation. The relevance of that is that it predicts resistance to the gefitinib treatment that she's on, and we have another drug that was just coming through at that time to treat it. Now, over this point, she was getting very poorly. Her brain metastases were worsening. She was at home on a syringe driver. She was actually too poorly to come to clinic. We got this result through, I think, one Friday afternoon, and I phoned her up and had a slightly slurred speech with her and spoke with her husband, and we thought, essentially, what have we got to lose? She's dying in front of our eyes. He came down to the cancer centre, picked up the tablets. We thought, they're usually fairly well tolerated. It's a tablet. She's on some tablets already. We'll try it over the weekend. This was in October last year. She walks into clinic, off a syringe driver, off all meds, and if you saw her walking down the street, you would not realise that she had cancer. So at the moment, things are going very well. I'm sure we've all got those things that we remember in our medical careers. There's usually less than 5, and certainly no more than 10, of times where you've really made a difference and go, that was incredible, and I'm so glad I'm a doctor. I've only got less than 10, I know that. This is one of those for me. It's really amazing. I've put an uncertain face here, though, because she is doing very well. We don't have any really good options of where we go next. So there are lots of developments, but we haven't fully answered the problem yet. This is one of those graphs I warned you about. So targeted therapies in lung cancer, there is now a very good evidence base. Very high response rates as long as you're treating people whose cancers have this specific mutation, and there are often minimal or manageable toxicities. There are not zero toxicities, though. They're convenient. They're tablets. So people come, I've got people who pick up tablets 3 months at a time and go on holiday and things like that between clinic visits. Challenges, though, who do we biopsy? These tablets can have dramatic responses for people's cancer. So that challenges the concept of you're too poorly for treatment. Because if that elderly, frail patient with advanced metastatic cancer has a cancer that's harbouring one of these mutations, you can do a lot of good for them by giving them this treatment. But we don't want to be biopsying everybody unnecessarily. We don't know which targeted therapy is best. There's some different ones to choose from, and we don't know about sequencing or combinations. One thing that comes up in clinic is it's genetics, but it's not a germline mutation. So people get worried when you talk about genetics, think, what about my kids? This is something that happens in the body. It's not something you could pass on. So we reassure people they don't need to test their kids. And this is just a graph highlighting patients in grey had chemotherapy, and the patients in red had one of these targeted drugs, and over time more of them survive. But the curve still goes down. So it's only an appropriate treatment for a very small number of patients, probably about 5% of patients with lung cancer. Long-term survival, that 5-year point is still poor. You get very good response rates, you can improve people's quality of life, but it still gets difficult. They're not cheap, and there is a small risk of serious problems. People can get pneumonitis, which can be life-threatening. And patients can be on these treatments for years, taking a tablet daily, and we can get chronic, debilitating side effects like sore mouth. They get a lot of acne-type skin reactions, a lot of nail changes as well, a lot of tenderness and pain around the nails. And that can really affect someone's quality of life, especially when they're on these for potentially quite a long time. So this is a lady with stage 4 metastatic lung cancer, presented with incipient spinal cord compression, also has brain metastases. But she's never been admitted to hospital. She's never had any chemotherapy. It's now 2.5 years post-diagnosis, when the average survival is 12 months in this sort of situation. And she currently has a good quality of life with minimal symptoms from her cancer and minimal side effects from her treatment. With targeted therapies, there's an overall shift from things like hair loss, nausea, vomiting, neutropenia and myelosuppression that we see with cytotoxic chemotherapy, to the mucocutaneous things, sore mouth, sometimes some diarrhea, skin problems and nail problems, which can be chronic and can be debilitating. And it is long-term treatment. Peter, he's got some comorbidities in the form of ischemic heart disease and COPD. He's married, lives with his wife. He's pretty independent, self-caring. He's lost some weight. He's got a cough. He's more short of breath. Denies any hemoptysis. He's not coughing up any blood. And he has a biopsy which shows squamous cell carcinoma. So we're still in the non-small cell land, but this is the squamous type. And he's been staged as having metastatic disease as well. T3, because the tumour's bigger, so the T gets a bigger score because his tumour's bigger. That's the tumour there. N3, the lymph nodes, little grey blobs, mediastinal lymph nodes, and M1 because his adrenal gland is a bit large on the left. So he's got metastatic squamous cell carcinoma. We're not thinking targeted therapies for him because he's a smoker, and the likelihood of having a targetable mutation in someone with a squamous cell carcinoma is very, very low. That's not a good place to be. So typically, as recently as last year, we'd offer Peter some palliative chemotherapy. Usually 2 drugs. One is a platinum drug, and we mix it with various other ones depending on some patient factors and other things. Usually giving that every 3 weeks. We might aim to give up to 6 cycles of chemotherapy depending on how things are going. And that depends on how the patient gets on with it, what impact on their quality of life there is, and how their cancer responds. So if you've got a patient who's tolerating chemotherapy well and the cancer's responding, we tend to give more chemotherapy than if they're struggling or if their cancer's progressing. With chemotherapy in lung cancer, there's a narrow therapeutic index. It's a close balance between helping and harming. And this is a conversation we have with patients in clinic when we're making a decision. Palliative radiotherapy is there as a possibility to the primary tumour or symptomatic metastases, and we'd involve the community or hospital palliative care team with all of these patients. Average life expectancy, 12 months, maybe less. So this year, there's a new test and a new treatment. We look to test for something called PDL1, that's Programmed Death Ligand. Kind of a scary name. So that's a test that our histopathologists will do, and the reason we do that is that can help predict whether someone's cancer will respond to immunotherapy. So tumours which have high levels of this PD-L1 tend to respond better to immunotherapy than tumours that have low levels. So we're testing a lot of people with lung cancer for this now. It's also being used in melanoma, renal cell carcinoma, so kidney cancer. I think it's coming in head and neck. There's probably some other tumour sites. Breast. So it's a real area of growth in terms of using this treatment. It's still given intravenously. It's usually every 2 to 3 weeks, and sometimes we use combinations of different treatments. And for lung cancer, we can give this treatment for up to 2 years. So that's quite a long-term treatment. But in some ways, it's good that there's a treatment that's available for 2 years for patients where median life expectancy is 12 months, because that gives us some encouragement that, well, if you're still having treatment, you should still be alive. Give that alongside palliative radiotherapy, and we still involve the palliative care team. I put a question mark against the median survival here because we're still feeling our way with this. Yes, we know the data from clinical trials. Clinical trials are always different when you apply them in the real world. So why would we look to give somebody immunotherapy? I think the benefits here are that this can apply to a larger group of patients. Probably about 2/3 of people with lung cancer would be suitable for immunotherapy, I would say, whereas these oral targeted therapies we were talking about before, it's only about 5%. So it's a much bigger group of patients. You can get long-term disease control. And this is in a cancer where we don't typically see long-term disease control. And there's not been many significant changes in patients with squamous cell carcinoma of the lung. A lot of the activity has been on the genetics and the targeted treatments. So it's really positive to have something new for these patients. And here again, just a couple of more of these survival curves that we love so much in oncology. And basically you can see the lines which patients had immunotherapy, they're doing better than those that didn't have immunotherapy. So there is that survival benefit. But there is, for some patients, a small, for other patients, a more significant risk of immune-mediated side effects. They can occur at any time during treatment and can occur for some months after we've finished treatment. This is very different to cytotoxic chemotherapy, where there's usually a kind of predictable cycles of side effects. So nausea, if it's going to happen, is in the first 24 to 48 hours. Infections, if they are going to happen, tend to happen day 7 to 14 as the blood counts dip and then they improve. This is very, very different. There's a completely different spectrum of side effects, and it's much less predictable. We're tending not to give patients with a history of autoimmune diseases these treatments, because if we're kind of stimulating and unmasking things in the immune system, if they've got a history of an autoimmune disease, it's likely to go very wrong. There is some data coming out that maybe we can start using them more broadly, but we're being very careful at present. There is a bit of a risk of tumour flare, because if you stimulate the immune system and get all those immune cells into the tumour, that makes things swell up. So if you've got somebody with a very big proximal lesion or brain metastases or something like that, you don't want them to swell. So there's a bit about patient selection and treating those patients who aren't too poorly and who don't have a cancer where if it grows a little bit, that'll cause serious problems. That does make assessing response challenging, because typically if we've got someone on treatment, we do a scan after a couple of months and see how things are shrinking or growing. But sometimes we see these cancers growing a little bit, and that's actually a marker of the immune system kicking in. So the radiologist's having a bit of a headache with us as well. Steroids can be very helpful, as they are in many autoimmune conditions, at quietening down these side effects. But if we're trying to stimulate the immune system to fight the cancer and we're giving steroids to quieten down the immune system, we can also reduce some of the benefit with steroids, so we have to be a little bit careful with that. These are seriously not cheap. And when we're looking at the patient numbers and the indications and the length of treatment, there's a big challenge there. There are some ways that we can predict response, so this PD-L1 testing and treating patients with higher levels and not lower levels, but that's not perfect. And we're still trying to work out ways that we can give the best treatment to each individual person. A little bit more on the immune side effects, because this is really important. As I said, the timing can be quite variable. Think of a part of the body and put itis at the end of it. So colitis is very common, and it can be like an inflammatory bowel disease, an acute presentation. Patients can get really poorly. Pneumonitis is a big thing that we see occasionally. Again, patients can get really sick. You can get hormone dysfunction, hypothyroidism, other hormone deficiencies, and dermatitis. Some patients get rashes as well. They can be potentially life-threatening, and patients do die of this from time to time, so we have to be really careful. And some of these patients end up on ITU for protracted periods of time. So they're not without their risks. A lot of the side effects are treatable, but I think this is one of those instances where we would liaise closely and work out what the best thing to do for the patient is, and even to the point of thinking, well, which hospital are they best in? Because they might be better off served in a hospital which has got ITU and HDU support. His primary tumour and his adrenal gland are both responding after about 2 to 3 months of treatment. So things are looking positive at the moment. Quizzical phase still, because we're not sure how it's going. It's still early. He could develop those side effects, and over time his cancer will grow and cause further problems, I'm sure. So summary, he's also got stage 4 lung cancer. We're still looking at palliative treatment, some radiotherapy for local control from his chest, and now he's on the immunotherapy, going reasonably well at the moment. And again, there's a shift in what we see from the traditional chemotherapy side effects to a longer term treatment with risk of immune mediated side effects that can occur at any stage. At the moment, we're just going to keep him on the treatment that he's on because he's tolerating it well. He actually says he's felt better than he has for months, so I suspect this cancer's been affecting his quality of life for a while. But there may be a twist in the tail. We can go back to chemotherapy or something like that afterwards, but it depends how well he is at that point. So, take-home messages, I hope. There are lots of new treatments. These are not just experimental treatments, these are in routine use day in, day out in clinic, and their indications are expanding, so the number of patients on these is expanding. There's significant benefit to patients in terms of better ways of controlling their cancer for longer. We are using them across more and more tumour types. We do still need to remain critical of the evidence base and not just apply these treatments indiscriminately. There are lots of new names, new acronyms, new technologies, new words to use, and there's new side effects and problems, and sometimes those new names and acronyms can get in the way of managing those side effects and problems because we start using a language that nobody knows and nobody understands. So thank you for helping us with that tonight by telling us which of those words are absolute mumbo jumbo to you, and then we can start communicating with you better just in the normal working week. And I think with these things, new ways of working are essential. We can't just keep doing more and more of the same and filling up clinics more and more. So there's a challenge there to all of us about how can we work better to look after our patients. And I think they are our patients. So there's a shared responsibility. And I think part of this evening is to start talking about that as well and what we might be able to do differently in the future. So thank you.